Chest pain is one of the most common presenting symptoms for patients to an emergency department. Of the serious causes of chest pain, cardiac ischemia is by far the most common, with an incidence of non-ST elevation myocardial infarction at about 400 cases per 100,000, compared to pulmonary embolism at only 66 per 100,000, or acute aortic dissection at 6 per 100,000. Unfortunately, in the absence of ST elevation on the presenting ECG, the diagnosis of acute myocardial infarction is difficult to make at the time of patient presentation because the history, physical examination, and chest X-ray all have poor sensitivity and specificity for the detection of acute myocardial infarction, and cardiac serum biomarkers may not become abnormal until many hours after the onset of ischemia. This slide shows the results of the initial electrocardiogram in nearly 4,000 patients presenting with chest pain to the emergency department. You can see that very few patients present with ST elevation or clear ischemic changes on the ECG. More than 85% of all the ECGs were considered normal or non-diagnostic. This slide shows the percentage of patients with elevation of cardiac troponin T or cardiac troponin I from the onset of chest pain. The sensitivity of cardiac serum biomarkers is very low until at least 6 or 10 hours after the onset of ischemia. Because the diagnosis of an acute myocardial infarction is difficult to confirm early after a patient's presentation, much attention has been focused on the use of ancillary imaging to help detect ischemia. Imaging methods that have been evaluated for this purpose include echocardiography, nuclear SPECT imaging, cardiac magnetic resonance, and CT coronary angiography. I have listed on this slide some of the attributes that I believe are important for an ancillary imaging tool to assess in order to be effective for detection of ischemia. First of all, the tool should be portable so that the patient does not have to be removed from a monitored acute care setting for imaging to occur. Of course, the test should be widely available, and ideally, it should not expose the patient to irradiation. Finally, an imaging tool to detect ischemia should also either directly detect myocardial blood flow to tissue, such as assessing perfusion, or it should assess some corollary of ischemia, such as wall thickening abnormalities. As you can see from this table, echocardiography actually has many of the aspects that make it an ideal ancillary imaging tool for the detection of ischemia. The ability of echocardiography to detect ischemia is based on the close relationship between myocardial blood flow, which is shown on the x-axis of this slide, and wall thickening, shown on the y-axis. Normal myocardial blood flow of about 1 ml per minute per gram of tissue is associated with wall thickening of about 25 to 30%. As soon as myocardial blood flow decreases below normal resting levels, a wall thickening abnormality will develop. So abnormal wall motion is a direct marker of acute myocardial ischemia. In order for echocardiography to detect a wall thickening abnormality, however, it is critical that all endocardial borders are clearly seen. As shown in this cine loop, though, a significant proportion of patients have suboptimal echocardiographic windows, and the majority will have inadequate visualization of at least one segment. This will significantly decrease the sensitivity of echocardiography for detection of ischemia, and methods must be used in order to assure that all endocardial borders are clearly seen. Microbubble contrast agents designed for echocardiography have made a dramatic impact on our ability to delineate the endocardial border. The currently available contrast agents both contain a high molecular weight gas of low diffusibility and solubility, which allows them to persist long enough after intravenous injection to opacify the systemic circulation. They are also encapsulated with a thin shell, which contains the size of microbubbles to less than 5 microns, so they are small enough to pass through capillary bed. This ASEUII loop shows the same technically difficult study that was shown before, but with the presence of microbubble contrast in the left ventricular cavity, we can now see that all endocardial borders are clearly delineated, and it demonstrates that this patient has normal wall thickening in each of the myocardial segments from this apical four-chamber view. This slide shows the impact of contrast agents on technically difficult echocardiographic studies. All the patients recruited into this study had technically difficult studies at baseline. The percentage of studies that were still technically difficult or uninterpretable after contrast use decreased from 98% to only 10%. Furthermore, the percentage of segments that were visualized increased from 68% to 99%. Most importantly, the percentage of patients with a new wall motion abnormality detected on echocardiography increased from 15 to 23%. The ability to accurately detect abnormal wall motion led directly to a change in patient management in this study. Microbubble contrast agents also possess a number of unique characteristics that make them excellent tracers of red blood cell flow. Unlike many of the contrast agents that are used for other imaging technologies, such as gadolinium with MRI or iodinated contrast agents with CT, the microbubbles that are used with echocardiography remain entirely intravascular. They therefore provide a direct assessment of only blood flow and volume and not of any interstitial space. Secondly, the microbubbles are entirely hemodynamically inert, so they do not affect myocardial blood flow like iodinated contrast agents used with radiology. Thirdly, the microbubbles have the same rheologic properties as red blood cells. This ASEUII loop shows fluorescein-labeled red cells and microbubbles passing through a 17-micron arteriole, which branches into two 11-micron arterioles. You can see that both the red cells, which are the larger, slightly irregularly shaped fluorescent bodies, traverse the microvasculature in exactly the same way as the microbubbles, demonstrating that microbubbles have the same microvascular rheology as the red blood cells. Therefore, if we can track the transit of microbubbles through tissue using echo, then we will be able to evaluate microvascular blood flow. The ability of echocardiography to quantify myocardial blood flow with contrast agents relies on the ability of ultrasound to actually destroy the microbubbles. This ASEUII loop shows a single microbubble under microscopy and the impact of ultrasound on it. With a single pulse of ultrasound, the microbubble breaks up and is destroyed. The method for quantifying myocardial blood flow with myocardial contrast echocardiography uses the ability of ultrasound to destroy the microbubbles in tissue, followed by an assessment of how quickly the microbubbles replenish the tissue. The rate of replenishment of microbubbles will be proportional to myocardial blood flow velocity. This slide shows sequential images from the apical four-chamber view in a patient who presented with chest pain to the emergency department. A corresponding pulsing interval versus acoustic intensity plot obtained from the septum is shown in yellow, and from the apex is shown in pink. The four images were obtained at different time points after the destruction of microbubbles in the myocardium. The apex, which has reduced resting myocardial blood flow due to the presence of ruptured plaque and a critical stenosis, shows slower replenishment rate of microbubbles, so there is less contrast enhancement of the apex at 300, 800, and 2400 milliseconds compared to the septum and lateral wall. even at 5 seconds after the bubbles have been destroyed, there is still a perfusion defect in the subendocardial region at the apex. The time versus acoustic intensity plot shows a slower rate of replenishment of microbubbles in the stenosed area at the apex compared to the septum, which is normal, as well as a lower plateau acoustic intensity. Because the low resting flow has resulted in some capillary derecruitment at the apex and therefore a lower myocardial or capillary blood volume. If a region with inadequate resting flow to maintain viability is not quickly and adequately revascularized, then infarction will result in capillary damage, as shown in the right lower panel of the slide, producing a fixed and permanent perfusion defect as demonstrated in the apex of the myocardial contrast echocardiographic image on the right upper aspect of the slide. I would now like to present some cases to demonstrate the diagnostic utility as well as the prognostic utility of contrast echocardiography in patients presenting with chest pain to the emergency department. In this case, a 60-year-old man without a prior cardiac history woke up at 5 in the morning with moderate 5 out of 10 dull retrosternal chest pressure, which he described as radiating to the left arm and was associated with diaphoresis. There was no associated shortness of breath, pleurisy, palpitations, nausea, or vomiting. The patient had never had any of these symptoms before, and he initially thought that they were heartburn, so he did not present immediately to the emergency department. He had a history of hyperlipidemia and was therefore on atorvastatin. He finally came to the emergency department because his symptoms were not improving with antacids, and he arrived about 2 hours after the onset of his symptoms. His initial electrocardiogram showed only nonspecific changes, and the emergency department sent off lab work, and when these returned, his first cardiac troponin I was negative. At that time, the patient was triaged to the chest pain center, but a cardiology consult was requested. Even though this patient has a very concerning history for acute cardiac ischemia, it is not possible to make a definitive diagnosis of an acute coronary syndrome based on the data that we have. Many patients like this would be admitted to a chest pain center or to the hospital for monitoring and serial assessments of cardiac serum biomarkers to rule out acute myocardial infarction prior to the use of definitive therapy for treatment of an ACS or AMI. In order to determine if the patient's chest pain was cardiac ischemia, and to do this more expeditiously, we decided to perform a contrast echocardiogram instead. The patient's apical fortune review is shown on this slide. You can see that the basal inferior septum, the mid and basal lateral wall are thickening normally, but there is a hinge point in the mid-septum with akinesis of the mid to distal septum as well as the entire apex. Since this patient has not had a prior history of cardiac disease or infarction, this is a new wall motion abnormality in the setting of his concerning chest pain and identifies that the patient is having ischemia in the left anterior descending coronary artery territory. We therefore did not have to wait for any further cardiac serum biomarkers or change in his electrocardiogram to make a diagnosis of an acute coronary syndrome, and the patient was sent to the catheterization laboratory. While the patient was waiting for transfer, we went on and did a myocardial perfusion study to evaluate blood flow to his septum and apex because he had presented at such a delayed time point after the onset of his chest pain, and we were interested to see if there was significant residual viability before sending him for revascularization. This slide shows contrast enhancement at different pulsing intervals after the destruction of microbubbles. At a short pulsing interval of every 1 per cardiac cycle, there is a significant perfusion defect in the distal septum and apex. However, as more time is given for the microbubbles to replenish the tissue at longer pulsing intervals, such as at every 4 and 8 cardiac cycles, you can see that most of the septum and apex have actually replenished well with microbubbles, and there is only a small residual subendocardial rim showing a perfusion defect. This suggests that the patient either has a subtotally occluded left anterior descending coronary artery with very slow anterograde flow to the apex, or the artery is actually completely occluded, but the patient actually has some slow collateral flow that is able to maintain viability and therefore microvascular perfusion in the septum and apex. This is the patient's coronary angiogram. You can see that there is a very critical stenosis in the mid-left anterior descending artery, and there is in fact very slow transit of radiographic dye down the left anterior descending coronary artery. The stenosis was able to be revascularized with a stent. The patient did extremely well in hospital and was discharged after just 2 days in hospital. This case demonstrates how contrast echocardiography was able to expediently make a diagnosis of an acute coronary syndrome in a patient, which led to institution of revascularization more quickly than usual care. In a large single-center study that was performed to evaluate the prognostic utility of contrast echocardiography in patients with chest pain, the results of multivariate logistic regression analyses for the development of early cardiac events is shown on this slide. Risk factors such as hypertension, diabetes, and clinical history, including age and sex of the patient, had very poor prognostic utility and did not help to risk stratify patients in multivariate regression analysis. If patients had an abnormal electrocardiogram, that was associated with about a 2-fold increased risk of an early cardiac event. RF, or regional function, actually had a 5-fold increased risk if regional function was abnormal. And you can see that the combination of abnormal regional function and abnormal myocardial perfusion at the very bottom of the graph was associated with a nearly 14-fold increased risk of early cardiac events, including death, acute myocardial infarction, unstable angina, and congestive heart failure, as well as revascularization within 48 hours after admission. Contrast echocardiography, therefore, is a very powerful tool for risk stratifying patients presenting with suspected acute coronary syndromes. In the second case, a 41-year-old female with a strong family history of coronary artery disease, but no other cardiac risk factors, presented with new onset exertional chest pressure to the emergency department. This patient was referred to cardiology very early after her presentation because the physicians were very concerned that she had unstable angina, and we were able to order a myocardial contrast echocardiographic study to be done while the patient was still having her acute chest pain symptoms. This cine loop shows the contrast-enhanced echocardiogram performed in the patient during chest pain. This is only her 4-chamber view, but it demonstrates entirely normal wall thickening in all myocardial segments with her ongoing symptoms. Views of the other windows also confirmed she had entirely normal segmental wall motion. This myocardial contrast echocardiogram evaluating perfusion in this patient also showed entirely normal replenishment of microbubbles into tissue over time, demonstrating that there was no ischemia using myocardial contrast echocardiography. This study was therefore able to confirm that the patient was not presenting with acute myocardial ischemia as the cause of her chest pain. The negative predictive utility of contrast echocardiography is also extremely good, as shown on this slide. Again, in this large study that included more than 1,000 patients evaluating the prognostic utility of contrast echocardiography for predicting early events, you can see that in patients who had normal regional function, the risk of a primary event, including acute myocardial infarction or total mortality, was only 0.4%. This is even lower risk than the usual management of patients, which has been reported to be associated with about a 2% miss rate, with patients being discharged from the emergency department with a missed acute myocardial infarction, which is unfortunately associated with quite a high mortality of up to 10%. Thus, if a patient has entirely normal regional function or myocardial perfusion with contrast echocardiography during their symptoms or even up to 12 hours after the onset of significant chest pain, they have a very low risk for the development of a heart event. The young woman who presented with chest pain to the emergency department could therefore be triaged rapidly for a stress test because we knew it was very unlikely that she had an acute coronary syndrome, and we wanted to make sure that her other history of exertional chest pain was not due to occult coronary artery disease. The patient was referred for an exercise stress system-AB scan. She exercised to 12.9 METs, achieved a peak heart rate of 188, which was 105% of her maximal age-predicted heart rate, and a systolic blood pressure of 190 millimeters mercury. Her exercise stress electrocardiogram was negative for ischemia, and as demonstrated in this slide, normal tracer uptake was seen in all myocardial segments, both at rest and at peak stress. We were therefore able to completely exclude any significant obstructive CAD in this patient. This slide shows the long-term prognostic utility of contrast echocardiography in patients presenting with chest pain to the emergency department. Again, those patients who have normal regional function and normal myocardial perfusion have a very low risk of events even up to 2 years after their presentation to the emergency department. In contradistinction, patients who have both abnormal regional function and abnormal myocardial perfusion have a significantly higher increased rate of cardiac events over 2 years, with about 50% of patients having events by that time. Patients who have abnormal regional function but normal myocardial perfusion were an intermediate risk group. These are patients who probably had spontaneous reperfusion and therefore just residual stunning, causing abnormal regional function on their study, but with normal perfusion, or they were patients with non-ischemic cardiomyopathy and therefore had normal myocardial perfusion. A number of composite risk scores, such as the TIMI risk score, have been developed for risk stratifying patients presenting with suspected acute coronary syndromes. The TIMI risk score, however, cannot be fully derived until the results of serum cardiac biomarkers are known. This would therefore result in a delay in complete risk stratification of a patient because, as shown earlier, it may take many hours for cardiac serum biomarkers to become abnormal. We therefore sought to develop a risk score that would utilize echocardiographic data instead of cardiac troponins. We developed a risk score which incorporated clinical and contrast echocardiographic variables based on data from 973 patients, the so-called development sample. All of these patients presented with chest pain to our emergency department. In order to validate the risk score prospectively, we applied the risk score in another large group of patients presenting with chest pain. Finally, we wanted to determine if serum cardiac troponin further improved the predictive value of our risk score. The clinical endpoints of our study were cardiovascular events at 1 year, which included all-cause mortality, non-fatal myocardial infarction, unstable angina requiring hospitalization, and revascularization. For subjects who had multiple events, only the first heart event either death or non-fatal myocardial infarction was counted. If they had multiple soft events, only the first was counted. We incorporated the clinical variables from the TIMI risk score, including age greater than 60, greater than or equal to 3 cardiac risk factors, the use of aspirin, more than 2 episodes of chest pain, ST segment change on the electrocardiogram, and known coronary artery disease into a multivariate analysis. We did not include troponin because that was usually not available immediately at the time of patient presentation. However, because an echo can be obtained rapidly at a bedside if the logistics are set up properly, we evaluated abnormal regional function on echo as well as abnormal myocardial perfusion. The odds ratio of these various variables are shown on the slide, as well as their corresponding p-values. You can see again that abnormal regional function is one of the most powerful predictors of adverse outcome. Based on the odds ratio of each of the variables in the risk score, we assigned each of the variables a numeric score as shown on this slide. The various scores could then be added to obtain a final risk score for any patient presenting with acute chest pain to the emergency department. The ability of the risk score to predict outcome over the next year is shown on this slide from our development sample. Patients were divided into 6 groups, ranging from a risk score of 0 to greater than 200. You can see that the risk dramatically increases as the risk score increases to higher and higher values. It is also very important to evaluate the cost effectiveness of contrast echocardiography, especially in today's healthcare environment where costs are becoming more and more constrained. It is potentially extremely expensive to add an echocardiogram, especially with the use of contrast, in all patients presenting with chest pain to an emergency department. However, we hypothesized that because myocardial contrast echocardiography has excellent negative predictive value and can identify low-risk patients who could be discharged from the emergency department, that contrast echocardiography could prevent unnecessary downstream resource utilization, mainly admissions to chest pain centers or hospital, as well as further non-invasive or invasive testing, which could then make contrast echocardiography a cost-effective tool for the evaluation of patients presenting with chest pain. In order to evaluate cost-effectiveness, we followed patient disposition in about 1,000 patients who presented with chest pain to the emergency department. We also cataloged all follow-up tests that were performed, including exercise or pharmacologic stress testing with nuclear perfusion or echocardiographic imaging, and patients who were referred for cardiac catheterization. Economic outcomes analysis was based on the national average of Medicare allowable charges for emergency department visits, inpatient DRGs, echocardiography, and nuclear perfusion imaging for 2006. Outpatient SPEC studies and all myocardial contrast echocardiograms done in the emergency department were billed for individually. The model that we used to determine cost is shown on this slide. Patients presenting with chest pain to the emergency department all underwent usual care. The results of contrast echocardiography was blinded to the emergency department physicians and consulting physicians. So all decisions regarding follow-up testing and patient disposition were made based on usual clinical criteria alone. Therefore, in the usual care arm, patients underwent the usual clinical evaluation. They were either admitted or discharged, and we followed those patients for respective outcomes. We then had a theoretical myocardial contrast echocardiogram guided care arm. This was based on the results of echocardiography. Patients who had entirely normal regional function and myocardial perfusion were discharged. Patients who had either abnormal regional function alone or both abnormal regional function and abnormal myocardial perfusion would have theoretically been admitted. And again, all these patients were followed for their respective heart outcomes. This slide summarizes the cost of the patients based on the two different approaches to their care. On the right-hand side of the screen shows patients who were evaluated using the usual care arm. Out of the 957 patients, the vast majority of patients were admitted to hospital, 641. The rest of the patients were kept in a chest pain center and were ruled out before they were discharged from the emergency department chest pain center. So overall, 95% of patients had a prolonged stay either in the emergency department or during a hospitalization before they were discharged. Of the 641 patients who were admitted to hospital, 200 were discharged within 24 hours. The total cost per patient using usual clinical criteria to guide their care was calculated at $5,000 per patient. On the left side of the screen, we have the results of myocardial contrast echo guided care. More than half of the patients had entirely normal myocardial contrast echo and could therefore have been theoretically discharged directly from the emergency department. However, that would have resulted in a slight miss rate of 0.4% of non-fatal myocardial infarction and 1 non-cardiac death. All the other patients would have been admitted to hospital. The total cost of MCE-guided care came out to only $4,100 per patient. So the total cost savings would have been about $900 per patient, or about $1 million in the total sample. It is important to realize, however, that in this case, the results of contrast echocardiography were blinded from the clinical data, and that probably accounted for the slight miss rate of acute myocardial infarction in the contrast echo-guided care group. In real life, if clinical history, wall motion, and myocardial perfusion are all taken into account simultaneously, it is possible that contrast echo would have performed even better without missing any patients presenting with acute myocardial infarction. We also performed a sensitivity analysis to see how high the cost of myocardial contrast echo would have to be before the contrast echo guided care strategy would be more expensive than usual care. As you can see, the cost of myocardial contrast echo would have to increase to more than $1,200 per study before contrast echo would become more expensive than the usual care approach. I have, up to this point, hopefully demonstrated the strong diagnostic and prognostic utility of contrast echocardiography for patients presenting with chest pain to the emergency department. However, there remain a number of limitations for echocardiography. The most important of these is that it is not possible using either wall thickening or even myocardial perfusion to differentiate between patients presenting with acute ischemia and those who have had prior infarction. In the future, it is possible that targeted imaging may help to further delineate whether patients are presenting with acute ischemia or whether their wall thickening abnormality is old. Secondly, it would be ideal if echocardiography could be used to detect occult coronary artery disease at rest. There are possible ways of doing this using assessments of changes in arteriolar blood volume, but this is beyond the scope of this present discussion. It has also been shown that the addition of contrast to 3D echocardiography can sometimes help to delineate epicardial coronary disease, and it remains to be shown in future if that will become a tool that can be used clinically at the bedside. 3D echo has other benefits in terms of looking at wall thickening, however, that I will cover shortly. This slide demonstrates how specific ligands could be attached to the microbubble surface in order to detect the presence of cell surface markers on the endothelium. One example of how targeted imaging could potentially help to distinguish acute ischemia from prior infarction is to use targeted microbubbles that could potentially detect the inflammatory response that develops with acute ischemia or reperfusion injury. This should be present only in patients who have acute ischemia and not in patients who have prior infarction. These images were obtained from an animal experimental model where the animal underwent 30 minutes of ischemia followed by reperfusion. The far left image shows a myocardial contrast enhanced image using microbubbles that were labeled with P-selectin, which can identify upregulation of inflammatory markers on the endothelial cell surface. The middle panel shows technetium RP517 imaging, which is a compound that will attach to inflammatory cells that have adhered to the inflamed endothelium. And finally, on the right-hand panel, we have a triphenyl tetrazolium chloride stained slice of the heart muscle, which demonstrates an subendocardial infarction. This particular animal had occlusion of the left anterior descending coronary artery, followed by reperfusion. The bright green and red signals identify the presence of targeted microbubbles that have adhered to inflamed myocardium in the perfusion bed that was previously ischemic. You can see that the entire perfusion bed is lit up very brightly with these targeted bubbles, and that the zone of ischemia exceeds the territory that eventually necrosed after 1 hour of occlusion. It is also matched with the nuclear image in terms of location of the area of inflammation, but again, the extent of inflammation on the contrast echocardiogram exceeds the nuclear image. So again, it is possible in future that specific targeted bubbles will be able to help us further refine our methods for detecting acute chest pain in patients. This is a clip from a normal patient. It demonstrates how contrast can also be used during 3D echocardiography to evaluate wall thickening. The main advantage of 3D echo is that we can potentially avoid foreshortening in patients and missing apical segmental wall motion abnormalities. And we can also slice the heart muscle into as many short axis or other planes as we want, and therefore potentially improve our ability to detect even a small segmental wall motion abnormality that might be missed if we use just our standard 3 imaging planes. Although this has not been proven yet, it is possible that techniques such as 3D echo may further improve our sensitivity for detecting acute ischemia and may therefore help to further decrease the risk that patients with a very small myocardial infarction would be missed. In summary, with this presentation, I have talked about how a number of different ancillary imaging tools can potentially be applied to detect acute myocardial ischemia. Echocardiography has many advantages over the other tools which have been studied because it is portable, it is widely available, it can be done quickly at the bedside, doesn't need post-processing to provide an assessment of either wall thickening or myocardial perfusion, and therefore could really be an important tool to allow us to more expeditiously make a diagnosis of an acute coronary syndrome in a patient with chest pain, or to rapidly exclude cardiac ischemia as a cause of chest pain, so that the patient could either be discharged or other causes for the chest pain can be sought.